This is not the time for you to be doing a complete head-to-toe assessment. I would not be a good nurse if I did not include that in my video. Hey everybody, and welcome back to my channel. My name is Beebee, and if this is your first time here, welcome. And if you are back for another video, thank you. So today I'm going to be talking about giving the perfect bedside report. Now, if you're a new nurse, this is one of those things that can sometimes seem very intimidating. You don't know what's important. Should you include it? Should you not include it? Am I talking too much? Am I not talking enough? Am I leaving important things out? So here, I'm going to divide this video into two different sections. The first part, I'm going to be talking about what exactly a good bedside report consists of. In the second section, I'm going to switch into my scrubs and I'm going to basically act out a really good, perfect bedside report for you. So if you'd like to know how to give a great bedside report, keep on watching. All right, so for me, a good bedside report always starts before the oncoming nurse even arrives. Around 5 o'clock in the morning, whenever I'm doing my last med pass, if my patient is alert and oriented, I go in and I let them know what is going to happen during the bedside report. I let them know that it's going to take about 5 minutes. We're going to be talking about your medical history, why you're here, and what the plan is. And the reason I do that is because I work night shift. And early in the morning, sometimes you walk in and you're trying to give a report, you're flicking on lights, you're anticipating you're gonna have to turn the patient, and they had no idea this was coming and they were just finally getting some sleep. So the reason I do this is because the patient is now anticipating your return. They're anticipating that it's only gonna take 5 minutes, and that way they're not annoyed when you come in and you start doing all these things and messing with them. The second thing that I always like to do is I reintroduce the bedside report to the patient with the oncoming nurse. So now it's 7 o'clock, you walk in with the oncoming nurse and you let the patient know you're here, this is your nurse so-and-so, and I'm just gonna be giving her bedside report. At this time, feel free, if you have any questions or anything you'd like to add, at this time, this would be appropriate to do so, or however you wanna word it. And then I jump into my bedside report. All right, guys, so once you've done your introduction, it's time to get into the bulk of your bedside report. Basically, all the information that you are gonna be communicating to the oncoming nurse. Now, you're always gonna start your report with stating the patient's name, their age, what they're admitted for, and who the doctor is. You're also going to talk about their medical history along with any surgical history that they may have. So it's going to sound something like this. Jane Doe is a 47-year-old female admitted for pneumonia and sepsis. She was admitted under the services of Dr. Gray with a consultation from infectious disease. She has a full code, no known allergies. Medical history includes hypertension, hyperlipidemia, and diabetes, all of which are being controlled during her hospitalization. Surgical history includes a splenectomy in 2013. So, the reason that you're including all this information in the beginning of your report is to give the oncoming nurse a better, well-rounded idea as to what is going on with the patient. You include who the doctor is, just in case they have to call, who the consults may be, or any consulting doctors. And the reason for this is, what if something comes up that is specific to why they're being consulted? The nurse needs to know this so she can call the appropriate doctor for whatever issue may arise or any orders that she may need during the shift. Because one of the most frustrating things is when you call the attending for an order and they tell you, well, was so-and-so consulted? Well, you need to call them. So that's why you do that. Always include who the consulting doctors are and why they were consulted in your report. You're also going to talk about their medical history and explain if any of those diagnoses in their medical history is being addressed during their hospitalization. So say the person has a history of hypertension, like I said in this example, you're going to always say that it's being controlled and managed, she's on PO, hypertensive medications. And the surgical history, you always state that as well, once again, giving the nurse a more well-rounded idea about this patient's status. So once you've given the nurse the background of your patient, their medical history, and all that jazz, you're gonna move into talking about why they're here in the hospital today. What brought them here? Why are they hospitalized? And I also like to include anything that may have happened prior to them getting to the ER in my little quick synopsis. So in this fictional situation, our patient has pneumonia and sepsis. So this part of my report is going to sound something like this. So Mrs. Smith about 5 days ago noticed that she was having a persistent cough and a slight temperature. She went on to medicate herself with some over-the-counter medications and realized that they were not working and that her symptoms were getting worse. Last night, she arrived to the emergency room where she was given 2 grams of Rocephin IV bolus and was put on 4 liters nasal cannula due to the fact that her O2 was in the 80s. Her labs showed lactic acid was 2.6 and her WBCs were 19.6. She was also tachycardic at the time of her arrival. Therefore, she screened positive for sepsis. After being determined to be stable in the ER, she was brought up to us with oxygen still on 2 liters of nasal cannula for comfort. So I basically at this point has given the nurse a background of what brought this person to the emergency room and what they did in the emergency room to get them stable enough to be able to come to the floor. Now this is very important because it kind of gives the oncoming nurse an idea as to what condition this person came in and how they're doing now, comparing the two. Okay, so after you talk about all that, you're basically gonna get into your head to toe assessment. So this is the part where you're gonna break it down and talk about everything, basically going through the whole systems, your neuro, your cardiac, your respiratory, GI, GU, as well as their skin condition. So you go through all that, and now you're going to talk about the IV site. Always mention the IV site. Do not forget the IV site. And when I talk about the IV site, I always mention the gauge, where it is, and when it is to be changed. If you are lucky enough to work at a hospital where their policy is that the IV can be left in until it's either soiled or not working, lucky you. But a lot of facilities now, it's a 3 or 4 day change that you have to take out the IV and put in a new one for infection control. So that's why I like to tell them how long it's been in and when it's due to be changed. I also mention at this point what is going through the IV, how often they're receiving medication through the IV, or is it just saline locked? And last but not least, I like to talk about the plan. This is very important because it allows the nurse to anticipate what may need to be done today, what still needs to be done, and how far this person is from being discharged. And also the patient likes this part too because it kind of lets them know like what else I gotta do to get out of here. So always include that in your report and always make it the last thing that you talk about. So after you give a brief synopsis as to what the plan is, you are going to ask the nurse and the patient if they have any questions. That way, if they had any questions, they can ask you and kind of get that out of the way. And last but not least, you're going to turn your patient and you're going to do focus assessments. If they have a wound vac, show the nurse that the wound vac is working, that there is no leak. If their bottom is open, show them what it looks like. This is not the time for you to be doing a complete head to toe assessment. I would not be a good nurse if I did not include that in my video because that is one of the pet peeves of a lot of nurses. 5 minutes. Remember in the beginning, we told our patient this should only take 5 minutes. So this is not the time for you to be doing a complete head to toe assessment. Only the important stuff that you need to visualize. Like I said, wounds, IV sites, check if they're on heparin to make sure that the order for the heparin is actually what is on the, oh my goodness, I just drew a blank. The IV machine. So make sure everything matches. Not head to toe. Do not whip out your stethoscope and start listening to lung sounds, palpating for pulses, not the time and place. The line of a good bedside report. And now I am going to change into my scrubs to get into character and give you the example from beginning to end to what a really good, perfect bedside report sounds like. So let's get ready. Good morning, Jane Doe. How are you? So as I explained earlier, I have your nurse Amy here and we are going to be completing your bedside report. During that time, it should only take about 5 minutes or so and I'm going to let you get back to sleep. We're going to be talking about your medical history, why you're here in the hospital, and what the plan is for you to be able to go home. If at any point during this report you'd like to add anything or you have any questions at all, please feel free to jump in. So Amy, are you ready? All right. So Jane Doe is a 47-year-old female. She was admitted for pneumonia and sepsis 7 days ago. She was admitted under the services of Dr. Gray with a consult from infectious disease. She is a full code, no known allergies, and her medical history includes hypertension, hyperlipidemia, and diabetes, all of which are being managed and controlled at this time. Her surgical history includes just a splenectomy in 2013. So just a little bit background. About 2 weeks ago, Jane started experiencing a productive cough along with fevers. She went to her local Walgreens and bought some over-the-counter medications and was taking that for approximately 3 days and noticed that her symptoms did not improve. That is when she came to the emergency room last night. When she arrived to the emergency room, her oxygen saturation was 88. She was tachycardic in the 1-teens. Her blood pressure was elevated and her lactic acid was 2.6 and her WBCs were 19.5. Thus, she screened positive for sepsis. It was at this time that she received 1 liter IV bolus of normal saline, 2 grams of IV Rocephin, and she was also put on 4 liters of nasal cannula due to her O2 being in the 80s. A chest x-ray was completed in the ER, which showed that she had lower left lobe pneumonia. After being treated in the ER, she came to us on the floor at approximately 2300, and she is still on O2. She is alert and oriented. Her gait is appropriate, but she does require some standby assist when going to the restroom due to the fact that she does desat when ambulating. She's on tele, normal sinus in the 80s, but sinus tach in the 1-teens with exertion. Her DVT prophylaxis is heparin sub-Q. She also has the bed alarm on her bed just as a reminder to call and not fall. Her respiratory status is that it is diminished throughout. Crackles can be left in the left lower lobe, and she does continue to be on the O2 at 2 liters. She receives breathing treatments Q6 with respiratory, and she has an order in there for PRN if need be, but she hasn't had to have it throughout my shift at all. As far as her GIGU, she is continent of both bowel and bladder, and her last bowel movement was 4 days ago. Last night, I did call the doctor, and he ordered Colace on the MAR BID, but I can still see, I can still hear her bowel sounds throughout, and she is passing gas. In addition, he did put in an order for milk of magnesia, so she doesn't have a bowel movement. By the end of the day, that is ordered for us to give to her. Her skin is intact, except there's some slight pink and blanchable redness on her coccyx. So we're gonna turn her at the end of the report so you can take a look. Her IV site is in the right forearm. It's a number 20 and is dated 5/7, so it's due to be changed tomorrow. She has normal saline going at 50 mLs an hour, and she has IV Rocephin scheduled Q8, and the next dose is due at 9 a.m. this morning. So as far as the plan, we got a repeat chest x-ray this morning that is scheduled. We're gonna be continuing her IV antibiotics and eventually bridging her to PO. She does have pending sputum cultures. They were able to collect that in the ER, and we're just waiting for the results of that. They also would like us to wean her off of the oxygen and for her to have a bowel movement today. So like I said, there is an order for milk of magnesia in the MAR. The labs for this morning, I did get a chance to go over them. She's on an electrolyte protocol and her potassium was 2.8, so I did order something for that, and I believe it's at 9 o'clock that she will be getting potassium. And the plan is for her to go home. DC home pending clinical improvement is what the case management notes read. So do you have any questions at all, Jane, for us? And Amy, do you have any questions for me? All right, so I'm just gonna put my gloves on and we can turn her and take a look, and also take a look at the IV to make sure everything is going fine. All right, thank you. All right, see guys, that was not so bad. That was pretty simple. And honestly, this outline can be used, and I kept it simple for a reason because not every unit is the same. And depending on where you work, there's gonna be unit-specific things that you're gonna need to include in your bedside report. Say you're working on a cardiac floor, you're gonna always wanna talk about your troponins and your heart casts or cabbages, or when the chest tubes came out. Trauma, you're gonna wanna know, when they had an X-fix and when it was internalized. Like, it's just a lot of unit-specific stuff. But this right here is just a really nice, simple, general med-surg outline that you can use on any unit, any floor, especially if you're lost and you're still not comfortable giving a complete bedside report. So I hope you enjoyed the video. If you loved it, please give it a thumbs up. If you have any questions or any other suggestions, there is a comment section down below. Feel free to leave them. I am great about responding to any of your questions, and I will see you next time. Happy nursing!